Okay. Hello everyone. This is Dr. Jessamine Dakanay, and today we'll be discussing the disorders of the mediastinum. So this is found in chapter 295 of the 21st edition of your Harrison's. So the learning outcomes for this lesson are: first, to recall the anatomy of the mediastinum; second, to discuss the mediastinal masses; third, we have the acute and chronic mediastinitis; and lastly, we have pneumomediastinum. So first, let's recall the anatomy of the mediastinum. So your mediastinum is the region found between the two pleural sacs. It's further separated into three compartments. You have your anterior mediastinum, seen in blue, your middle mediastinum, seen in yellow, and your posterior mediastinum, which is seen in orange. So your anterior mediastinum is bordered anteriorly by the sternum and posteriorly by the pericardium and brachiocephalic vessels. It contains the following structures: your thymus gland, anterior mediastinal lymph nodes, internal mammary arteries, as well as veins. Next, you have your middle mediastinum. So this is found between the anterior and posterior mediastinum, and it contains the following structures: your heart, your ascending and transverse arch of aorta, vena cava, brachiocephalic arteries and veins, phrenic nerves, trachea, main bronchi, contiguous lymph nodes, as well as the pulmonary arteries and veins. And lastly, we have the posterior mediastinum, which is bordered anteriorly by the pericardium and trachea, and posteriorly by the vertebral column. It contains the following structures: your descending thoracic aorta, esophagus, thoracic duct, azygos and hemiazygos veins, as well as the posterior group of mediastinal lymph nodes. So the first condition we can encounter in your mediastinum are your mediastinal masses. So usually these are just incidental findings, meaning when we do a routine chest x-ray, we sometimes encounter soft tissue densities in the mediastinum. So the first step in evaluating a suspected mediastinal mass is to try to place the mass into one of the three mediastinal compartments. So your CT scan, chest computed tomography scan is the most valuable imaging technique in evaluating these mediastinal masses. Other diagnostic tests that we can request include your barium studies. So these are for your gastrointestinal lesions. So if you have hernias, diverticular, or achalasia, then barium studies would be the best diagnostic test to request. While your iodine 131 scan is requested if you're suspecting an intrathoracic goiter. And mediastinoscopy, this is insertion of a scope into the mediastinum, can also be done. Or you have your anterior mediastinotomy, that's an incision into the mediastinum, can also be done. So this can be done to have a definitive diagnosis of your anterior or mediastinal masses. So if you do your mediastinoscopy or your surgical incision, then you can get a sample of that mediastinal mass and send it for analysis. Other ways by which we can establish diagnosis without doing your open surgery would be to request for your FNAB, that's your percutaneous fine needle aspiration biopsy. You can also do your endoscopic transesophageal biopsy. So a scope is inserted into the esophagus, and if there is a surrounding lesion, such as lymph nodes, then we can do biopsy of those surrounding lesions. Another is to do your endobronchial ultrasound guided biopsy, or your EBUS. So here we insert a scope into the bronchus and again see if there are any surrounding lesions, such as masses or lymph nodes, and we can do biopsy through the bronchus into the lymph node. And we can also do your VATS, your video assisted thoracoscopic surgery or thoracoscopy. And here we insert a scope again into the mediastinum, no? And this video scope can show you the appearance of the lesion so that you can have proper diagnosis, no? So inside the mediastinum, we can get a biopsy, and sometimes they can actually do incision, no, of the mediastinal mass so that we can come to the correct diagnosis. Okay, so we've learned the anterior, middle, and posterior compartment, their boundaries, as well as their contents. No? So when you have a mediastinal mass, so the first thing to do is try to place the mass into the different compartments. So is it coming from the anterior, the middle, or the posterior compartment? If you see a mass that appears to be coming from the anterior compartment, then you have to think of the following conditions. You have your thymoma, lymphoma, keratomatous neoplasms, thyroid masses, parathyroid masses, mesenchymal tumors, your giant lymph node hyperplasia, or a hernia through the foramen of Mergagni. On the other hand, if your mass seems to be coming from the middle compartment, then think of the following possibilities: your metastatic lymph node enlargement, granulomatous lymph node enlargement, such as in TB, your pleuropericardial cysts, bronchogenic cysts, as well as masses of vascular origin. And lastly, if you see a mass that seems to be coming from the posterior compartment, then think of the following lesions. You can have neurogenic tumors, meningocele, meningomyelocele, gastroenteric cysts, esophageal diverticula, hernia through the foramen of Bokdalek, as well as extramedullary hematopoiesis. Okay, so for the mediastinal masses, the management would depend on the kind of mass that you were able to find. Next condition is your acute mediastinitis. So mediastinitis means there is inflammation and infection in your mediastinum. So since there is infection, you would expect that these patients will be acutely ill. They will be febrile, usually with chest pain as well as dyspnea. You have here the common causes of your acute mediastinitis. First is your esophageal perforation. Second, after median sternotomy for your cardiac surgery. And third, infection descending from the neck, oral cavity, or facial area. So your acute mediastinitis due to esophageal perforation can actually occur spontaneously. For example, if a patient sneezes while closing the mouth and pinching the nose. No? So there would be nowhere for the force of the sneeze to go to, and that can actually rupture, no, the esophagus. Another more common way is the insertion of certain scopes or tubes, no, into the esophagus. So your esophagoscopy or endoscopy, or the insertion of your Blakemore tube, which is for esophageal varices, while doing those procedures, can rupture the esophagus, no, leading to your entry of secretions into the mediastinum. So this can cause your mediastinitis. So the treatment for this would be to explore the mediastinum. So we would need to open up the patient's mediastinum. We would have to repair the esophageal tear and drain the fluid, no, that is found in the mediastinum or even the pleural space. Next cause is mediastinitis occurring after median sternotomy. So median sternotomy is the usual surgical incision done for your coronary artery bypass grafting. So after your median sternotomy, acute mediastinitis can occur in around 0.4 to 5% of cases. The most common presentation of which would be drainage, no? Wound drainage or pus coming from the anterior mediastinal area. Okay, so most of the time after doing bypass, no, we have to check, monitor the wound if it's healing well or if we're finding any pus coming from that wound. Other presentations for these patients would be sepsis, so they're hypotensive, could be febrile. There might be a widened mediastinum on chest x-ray, and to confirm that there is infection in the mediastinum, we would need to do needle aspiration of that fluid. So we send that fluid to the laboratory, so that we can get a gram stain and culture of that fluid. So treatment, we would need to do immediate drainage and debridement of the area. No? So after the patient undergoes bypass, you would have to subject them again to a repeat surgery just so you can remove that pus inside the mediastinal area. And while waiting for the surgery, we have to start the patient on IV antibiotics, usually broad spectrum antibiotics, just to start the eradication of that bacteria. Okay? Mortality, however, is still quite high. It's more than 20% even after doing your management. Next condition is your chronic mediastinitis. So you have two conditions for chronic mediastinitis. You have a granulomatous form of mediastinitis. So this is just a granulomatous inflammation of the lymph nodes in the mediastinum, such as what we see in your tuberculosis. No? Another is your fibrosing mediastinitis, wherein there is a widespread fibrosis in the mediastinum. Okay? Most common causes of your chronic mediastinitis would be histoplasmosis, tuberculosis, which is more common in the country. Other rarer causes would be your sarcoidosis, silicosis, and other fungal diseases. So most patients with granulomatous form of chronic mediastinitis are usually asymptomatic. No? So they only have granulomatous inflammation of their lymph nodes. No? So this usually does not cause any symptoms. However, if you have a fibrosing form of chronic mediastinitis, there is widespread fibrosis in the mediastinum, and this can lead to compression of your important mediastinal structures, such as your superior vena cava, large airways, phrenic, recurrent laryngeal nerve. You can have obstruction of your pulmonary arteries as well as pulmonary veins. Okay? So treatment, if you have compression of these structures, then stents can be placed so that there can be relief of the obstruction of those structures. And lastly, we have pneumomediastinum. Okay? So when we say pneumo, that means air. So there is air or gas in the mediastinum. And you have three common causes of your pneumomediastinum. The first is your alveolar rupture with dissection of air into the mediastinum, such as what happens during mechanical ventilation. No? So during mechanical ventilation, the ventilator gives positive pressure breaths. So if you have a very large volume or a very high pressure of that breath, then it can actually rupture the alveoli. No? And if you rupture the alveoli, the air coming from the alveoli will now go into your mediastinum or the pleura. So you can have that pneumomediastinum. Next is you have perforation or rupture of the esophagus, the trachea, or the main bronchi, such as in your blunt force trauma, such as in vehicular accidents. No? So during vehicular accidents, that blunt force trauma can cause sudden rupture of these structures, leading to entry of air from the esophagus or trachea into the mediastinum. And lastly, you have dissection of air from the neck or abdomen going into the mediastinum. So, for example, in laparoscopic surgery, they usually insert air into the patient's abdomen so that they can have adequate space to perform the surgery. However, in rare instances, some of the air might go into the mediastinum, leading to your pneumomediastinum. So symptoms, patients with pneumomediastinum can experience a severe substernal chest pain with or without radiation into the neck or arms of the patient. On physical examination, you might notice subcutaneous emphysema in the anterior chest wall. No? So this is presence of air underneath the subcutaneous tissue. So if you try to compress the anterior chest wall of the patient, no, you might encounter a bubble-like or popping sensation, no, such as when you're trying to pop yung bubble wrap. So that's the sensation, no, if you have subcutaneous emphysema, no. So more commonly seen in your suprasternal notch. And you can also encounter the Hammond sign or Hammond's crunch. This is a crunching or clicking noise that is synchronous with the heartbeat and is best heard on a left lateral decubitus position. So when your heart beats, it doesn't stay still. No, it usually moves forward and backward in your mediastinum. So while it moves forward and backward, it actually causes compression of your mediastinal structures. And if there is air in the mediastinum, then that movement of the heart will cause the crunching or clicking noise, no, because of the compression of the air in your mediastinum. No? So that's why it's synchronous with the heartbeat. And of course, if you try to place the patient on a left lateral decubitus position, your heart moves closer to the chest wall. No? So that's why it can be heard louder, that crunching or clicking noise. Okay. Also, to diagnose, we can confirm the presence of pneumomediastinum by doing your chest X-ray. No? So on chest X-ray, you might see subcutaneous emphysema. So these black lines actually show us presence of air in the subcutaneous tissue. So that's subcutaneous emphysema. And here you have that dark line between the heart and the lungs. So that dark line is your pericardial pleural line. There's a separation between the pericardial pleura and the visceral pleura of the lung. So usually there is no space, no, between the two. But if you have air between the two structures, then that's when we can see that visible pericardial pleural line. Okay. Finally, treatment. If the pneumomediastinum is small, then usually no treatment is required. But if you have a larger pneumomediastinum, you might need to give the patient higher concentrations of oxygen just to facilitate faster reabsorption of the mediastinal air, no? Similar to what we do in your pneumothorax. And lastly, if your patient has signs of compression, no? Such as if the patient becomes hypotensive, no? Because of compression of your vascular structures, then you might need to do needle aspiration. So this needle aspiration is insertion of a needle under the sternum, no, into the mediastinum. This is usually done under ultrasound or 2D echo guidance so that we can avoid any complications. Okay, so that's all for your mediastinum. Thank you very much for listening, and I hope you learned all the topics.